So, hello everyone, and welcome to today's webinar series, Day 2, by Team Homeopathy 360 in collaboration with Asha Homeopathic Academy and the Homeopathic Key. A very warm afternoon to our esteemed guests and colleagues. For all of you joining us and already joined, I, Dr. Yashika Arora, heartily welcome you all, and I will be the moderator of today's session for all of you. But before I begin the session, I just want to introduce you to B.H.M.S online education platform, that is Homeopathy 360, as well as Asha Homeopathic Academy and the Homeopathic Key. Homeopathy 360 is one of the most updated portals for online publication of all kinds of course material for students as well as practitioners, latest news, upcoming events, research papers, articles, job vacancies, journals like Homeopathic Heritage and Homeobuzz, presentations, various videos on different topics. We have always tried to connect homeopaths worldwide and broadcast their talent, aiming the advancement of homeopathy as an evidence-based science. Homeopathy 360 has been an exceptional education hub for each generation of homeopaths, whether he's a clinician or a researcher or a student. We try to organize each and every single information related to homeopathy and make it universally accessible at www.homeopathy360.com. I also would like to invite all the esteemed homeopaths who are present with us right now to contribute your knowledge, your experiences in the core area of your expertise. For that, you can mail me at yashika@homeopathy360.com. And not testing much of your patience, let me just tell you that the uniqueness of the webinar lies in reaching each one of the learners personally and allowing every learner to raise questions to our speakers and get their answers right away. So on your screens, you have a chat box wherein you can type your questions and send to us by pressing the button next to the box. We'll be running a question answer session at the end of first speaker, that is at 3:55, and after the second speaker, that is at 4:55 around, wherein you can clarify your queries from the speakers. And before beginning the session, I just want to thank Mr. Manish Jain, the director of B.H.M.S Publishers, who is behind this webinar series, as well as Asha Homeopathic Academy and the Homeopathic Key, who have collaborated with us during this series. Asha Homeopathic Academy is from Indore, India, who's holding seminars for doctors and students, case presentations for doctors, and clinical case discussions for building homeopaths, as well as discussing and promoting homeopathy through their various social portals, through Homeopathic Junction page, as well as Asha Homeo Health Center. I also want to thank Dr. Yamini, Dr. Priyanka, Dr. Jasmine, and Dr. Vaibhav from their team for contributing to this webinar series, as well as Dr. Jitesh Sharma from the Homeopathic Key, a platform that is being created for all homeopathic doctors and upcoming homeopathic students. Their mission is to promote and discuss all information that is related to homeopathic world and stay connected stay connected, as well as updating the fraternity in order to connect every classical homeopath across the world with case studies, learning materia medica, discussions, they're discussing their issues in homeopathic practice, keep sharing their case experiences and make learning easier and better. So I'm thankful to each one of them for contributing to this series. And now it's high time that I should introduce the speakers of today. So I would like to welcome both of them. There is no smarter professor than life and no wiser sage than experience. He possesses the talent to make a subject which people dislike, or he can create such an aura in the class that me myself get excited to show up to and learn from him. He is being popular for giving amazing lectures and feedbacks, and always being supportive in the fraternity for each homeopath, each colleague homeopath. His dedication and love for homeopathy is so inspirational. A third generation homeopath, Dr. Navneet Bidani, sir, we welcome on behalf of Team Homeopathy 360 and Asha Homeopathic Academy, as well as the Homeopathic Key. He's having a successful track record of treating thousands of patients suffering from acute and chronic diseases with homeopathy and psychotherapy. He's completed his B.H.M.S from Pune, as well as had a keen interest in psychology. So he completed his master's degree in psychology, M.Sc psychology from Meghalaya with flying grades. He is highly skilled in treating the so-called chronic incurable diseases and has an extensive knowledge relating to human psychology, personality disorders, psychosis, stress apart from other physical complaints. He has completed his MD Home in Pediatrics from B.R. Ambedkar University, and he is a respected mentor who is specialized in homeopathic repertorization and case taking. Spreading his knowledge about right and healthy living in the society, organizing seminars, awareness campaigns is his biggest passion since graduation days. He's presently practicing at Dr. Bidani Center for Homeopathy, Hisar, and has contributed a lot to the homeopathic fraternity through various lectures, through various responsibilities for different organizations, and is well known as an international speaker, mentor, and teacher, and has given lectures in numerous national as well as international seminars, and has been a well-established author, and has written more than 100 articles for various international and national journals, peer-reviewed journals, and health magazines. He has a great number of achievements. So whatever I say is less to describe him. I hope everybody is excited to learn from him. But before we start, I want to introduce our second speaker who will be with us soon, will be joining us soon, Dr. Sheetal Bidri, ma'am. She's a passionate homeopath and a holistic health enthusiast who graduated B.H.M.S and M.D. Home in Pediatrics from Government Homeopathic Medical College and Hospital, Bangalore. Inspired to pursue homeopathy at greater heights by learning under Dr. Usha, she completed the basic modules and SCPH from the School of Predictive Homeopathy and has learned from doctors in Bangalore, Pune, Mumbai, Kolkata, including Dr. Sanjeev Dole sir, Dr. Aurang Gaikwad, Dr. Sunirmal Sarkar sir, and has got an extensive training under Dr. Rajan Shankaran sir through his WWR series online education portal. She has been instrumental in editing of books like Just You Think by Dr. Sarkar and decoding mental rubrics and materia medica of nosodes and sarcodes by Dr. Gaurang Gaikwad. And she has also shared her learning and experiences through various seminars, webinars, articles, and on social media. Currently, she has great interest in holistic living, nutrition, and fitness. She's practicing in Bangalore at Happy Healing Holistic Homeopathic Clinic, where she's serving the needy and continues to be passionate as ever in learning homeopathy as well as sharing her experiences breaking the myths of homeopathy. So she'll be discussing on growth and development. Her topic for today would be growth and development. So now I want to welcome Dr. Navneet Bidani sir, who will be our first speaker of the day. He'll be discussing on treating atopic dermatitis in children. So I hand over the session to him. Over to you, sir.
Yeah. Hi, everyone. It's an honor and a privilege to be here this afternoon. And I'm highly thankful to the B.H.M.S team, Homeopathy 360, Asha Homeopathic Academy, and of course, Homeopathic Key. So today, without wasting much of your time, because we already have I've got just 45 minutes more. And today, what I'll be sharing with you is my clinical experience of 20 years, and specifically in atopic dermatitis. In those years, I have learned. In fact, I have, treated more than, I would say, 300 to 400 patients of atopic dermatitis. What I mean by treated is that even after follow-up of at least 2 years, I'm counting those people only, those who were even without any medications. There was no relapse, and there was no aggravation, no seasonal aggravation, or maybe no as such environmental changes that causes the relapse of the patches or maybe itching or dermatitis in such patients. So I think we'll start with the topic. Yashika, can you share the slides, please? Yeah, thank you. So my topic for today is atopic dermatitis beyond scratching the surface. So why this particular line, beyond scratching the surface? In it itself, everything has a cause. Every disease is having some deeper roots. It's not just that it's the itching, so it's a superficial layer, the epidermal layer that is being affected, but it's the entire body. Or maybe you will later on in my slides, I will show you how mind is related with such kind of disorder as well. So today's topic is atopic dermatitis beyond scratching the surface. As you all know, it is a pruritic eczematic dermatosis, the symptoms of which chronically fluctuate with remissions and relapses. So, this particular point, remissions and relapses, is really very important because at times out of our overconfidence or at times out of, when we are in very much hurry, we declare our patient that yes, I have cured this particular patient having atopic dermatitis within 6 months. So, my dear friends, we'll have to be a little bit patient to declare to stop the follow-up of the patient because in most of the patients you get the relapse. Maybe many of the patients get relapse in the winters. So at times it's really difficult to judge whether that person, that patient will get the same symptoms in the next winters. So my dear friends, at least 2 years of follow-up is must in such kind of disorders. So what exactly is atopic dermatitis? Personal or family history of any or number of these illnesses like asthma, allergic rhinitis, allergic conjunctivitis, or atopic dermatitis, and having predisposition to overproduction of IgE antibodies. One very common question usually students ask is whether eczema and atopic dermatitis are one and the same thing. So my dear friend, technically, if I say technically, eczema is slightly different and is a more general term. And atopic dermatitis is just a type of eczema, but many physicians and patients will refer to atopic dermatitis and eczema as one and the same thing, though it's not exactly one and the same thing. So what's the difference? So eczema is a broad term, and atopic dermatitis is one of the eczema. Like there are a number of several types, different types of eczemas are there, like atopic dermatitis, contact dermatitis, dyshydrotic eczema, nummular eczema, seborrheic dermatitis, stachys dermatitis, etc. So though there are several distinct types of eczema, it is possible more than one type of at a time. So it is quite possible that if a same person is having contact dermatitis along with seborrheic dermatitis. The hallmark of atopic dermatitis are intense pruritus, chronic eczematous skin lesions, and epidermal thickening and hypertrophy. I won't go much into the theory part, so we'll go fastly in this particular thing because the theory you all people know very well. The most common presentation is that of infants, usually younger than 6 months, brought in by their parents for a persistent rash. Before coming to the homeopathic doctor, the parents may have tried a number of over-the-counter medicines, including topical steroids and home remedies. Parents usually report that the rash has waxed and waned for months and with a history of dry skin since birth. We homeopaths should inquire about a family history of asthma, hay fever, allergy, and other atopic diseases. Patients with pertinent medical or family history tend to have worse prognosis. So parents may also give a history of poor sleep or increased irritability in the patients, which is due to the desire to scratch the skin during sleep. Atopic dermatitis begins with intense pruritus, leading the patient to scratch which results in the characteristic rash. So there is a vicious cycle: itch, scratch, infection, inflammation, leading to more itch, more scratching, more infection, and more inflammation. And one thing we should learn: whenever we describe any skin lesion, it is very important to know the following features. Even when you are examining your patient having any sort of skin disease, you must focus on these 6 points: size of lesion, type of lesion, shape and symmetry of lesion, color and pigmentation, surface area, and distribution over the body surface. For example, if the lesions are symmetrical or asymmetrical, as is seen in, you know, uh, even in scarlet fever, there is a universal symmetrical pattern. So we have to understand whether the itch is localized or generalized. For example, in atopic dermatitis, the itching is localized, having characteristic sites, you know, and generalized itching is seen in sort of drug eruption, systemic diseases, psychogenic pruritus, exanthema, etc. We also should focus on sequence of events, like whether the itch precedes rash or rash precedes itch. Even though it helps in selecting a homeopathic remedy as well, even though it helps in selecting the rubrics, and at the same time it helps us in speaking the language of modern practitioners. So so we must know, we must ask the sequence of events from the patients. So, for example, if the itch precedes rash, it might suggest systemic disorder or psychogenic pruritus. And whereas if the rash precedes itch, it is suggesting more of a cutaneous problem. So, similarly, we must ask about the character of the sensation, pattern to the episodes of itching, time of the day of aggravation, does it awaken patient, are activities interfered with, what are the provoking or relieving factors, aggravating factors and all. This also, it's been classified into 3 parts: acute, subacute, and chronic atopic dermatitis. Acute one is having an intensely itchy and present as vesicles and blisters with intense redness. In subacute, you get the slight to moderate itching, and in chronic, you get excoriations as well, with accompanied by fissures and all, and then itching is quite intense as well at times. The next important thing while defining or while diagnosing atopic dermatitis in your patient is the pattern of skin manifestation. And it depends, it varies with the lifespan. How? Let's see. In infantile atopic dermatitis, pruritic, red, scaly, and crusted lesions are typically found on the extensor surfaces and cheeks or scalp, with severe cases possibly presenting with vesicles, exudates, or crusting. So, my dear friends, these are the common site. At times, while repertorization, when I was quite young, what I used to do was, like, if the patient is having eruptions over, say, forehead, I immediately take a rubric like itching, forehead. So we should never focus on such clinical symptoms, because it's quite a common thing. Most of the infantile of atopic dermatitis, you will see the rashes either on face, scalp, trunk, extensor surfaces of the extremities. So, my dear friends, there's no point taking such common rubrics while repertorizing. There's no point increasing your number of rubrics. So, better focus on the quality of the rubrics. So, in infants, you will get the region over these surfaces, and as the child grows, during childhood, the lesions in the childhood stage have less exudation. The skin often demonstrates lichenified plaques in a flexural distribution, commonly antecubital and popliteal fossa. So this is very common, and the commonest mistake we do is that we take such rubrics: itching at the flexural part, antecubital and popliteal fossa, as I mentioned before. So out of, I would say, uh, 10, 8 children will have atopic dermatitis on these surfaces only. So there is no point immediately giving graphitis just because in graphitis it is written that the itching is on the flexural folds. Of course, there are a number of many other medicines as well where it is mentioned. So the point is, such symptoms of a disease are of least importance while taking a case, while repertorizing the case. Similarly, in adults, you will get the distribution to that in adult eczema or maybe dermatitis. They have a similar distribution to that in childhood atopic dermatitis, but is increasingly localized and lichenified with thickened skin, increased skin markings, and excoriated and fibrotic papules. So in adults, most of the commonest site where you get the lesions of atopic dermatitis are upper arms, back, wrists, hands, fingers, feet, and toes. So just to revise, in infantile type, face scalp; in childhood type, flexural folds; in adult, upper arms, back, wrist, hands, etc. I'm going quite fast because I want to focus more on the homeopathy part. So quickly we'll revise the causes of atopic dermatitis. Most experts believe that atopic dermatitis has a genetic basis. This is of course supported by clinical studies as well as twin studies and chromosomal studies. So they suggest that there is a gene on chromosome 11 that is responsible for such disorder. And of course, clinical studies have also shown a higher risk of atopy in children with maternal atopy than in children with paternal. So in this slide, you should ask for a family history as well. Of course, like any other autoimmune or any other allergic manifestation, even atopic dermatitis is having environmental as well as genetic factors. So there is an array of gene and gene environment or immunological interactions. Of course, it is related with stress. Stress is one of the most commonest factor. And my dear friends, don't consider that children don't take any such stress. We'll discuss some other day about the stresses in children. So these are the other factors like immune dysfunction, nervous system imbalances, a higher level of substance P, impaired skin barrier, family history, of course, environmental pollution, excessive hygiene. At times we get patients who are having kind of an obsession of washing hands and all. Even that can lead to such sort of lesions, which we term as atopic dermatitis at times. Of course, trigger factors are dry skin, irritants, emotional stress, allergens, heat and sweating, and infections, secondary infections. So like soap can aggravate, temperature can aggravate. So these all environmental causes can be the reason and can be the reason behind the aggravation of these problem, these rashes and itching. Dry skin, soaps, temperature high and extremes of temperature, I would say. Some people are having allergy to fabrics. So this is also one of the positive factor, or you can say maintaining cause. Unless and until we remove these obstacles to cure. If a person is having some allergy to the synthetic thing, so it's better to avoid those synthetic fabrics and all for quite some time till the time your body get healed internally as well as externally with the help of right homeopathy, right constitution medicine. Of course, we should consider the psychological factors as well. because sleep disturbances because of itching can affect behavioral pattern, educational development in children. Teasing and bullying leading to low self-esteem, increased dependency and clinginess, impact on school or leisure time activities, time commitments for treatment applications and healthcare visits, disruptions to family function and relationship, and parental or stress and exhaustion. So now is the most important point, that is how we'll proceed with the case, or maybe what's the homeopathic perspective behind atopic dermatitis. So for that, we'll have to focus more on the problem, then only we'll get to the solution. So theoretically, we just briefly discussed what exactly is atopic dermatitis, what are the causes behind atopic dermatitis, what are the aggravating factors that can increase the itching or lesions of atopic dermatitis. But what exactly was the cause that was responsible for developing atopic dermatitis, say after 3 years, 4 years, 7 years, up to the age of 7 years or up to the age of 10 years, the patient was perfectly all right. Genes was same, environment was same, stress, if you consider, say, stress was same. So what happened all of a sudden that he started having rashes, that he started having itching, and that is increasing day by day, so gradual increase in the lesions. What was the factor behind? So we'll have to understand the cause behind the problem in order to seek the solution. So let's uh, take a deeper view about how to treat such a nasty disease. So let's take a review of literature before proceeding. According to homeopathic guidelines, the patient is to be treated not his organs or parts or systems or tissues. So also in a case of atopic dermatitis, our objective of treatment is patient himself, not the skin lesions. So as is written in aphorism number 82 of Organon of Medicine, that no real cure can take place without a strict particular treatment. So individualization of a case of disease is must. So our aim is not merely to reduce the hypersensitivity of skin along with skin lesion, but to have improvement in both subjective and
Sir?
objective fear. Yeah.
सर
Yes, please.
सॉरी आपको 1 मिनट इंटरप्ट कर रही हूँ, वो थोड़ा सा ना या तो स्पीकर थोड़ा सा लाउड कर लीजिए या फिर थोड़ा पास से बोल लीजिए. देयर इज सम इशू विद द ऑडियो.
Okay. Is it okay now?
यस सर, अभी ओके.
Okay, so what I was saying was that we have to focus upon the constitution, of course, and of course we'll have to take our case as per the individualization, what we have been taught so far. An older, more chronic disease will yield somewhat later together with all traces of discomfort by the use of several doses of the same more highly potentized remedy, or after careful selection of one or another more similar homeopathic medicine, as is written in aphorism number 148. And further, Hahnemann mentioned in aphorism 171 the same thing, the role of antisoric remedies, the well-selected homeopathic individual remedies. And yeah, this is a very important point. T.P. Pasturo, he writes that every experienced homeopath knows positively that unless he reaches the dynamic constitutional background of the patient, unless he had penetrated and understood the psychological personality and the vicissitudes of adaptation of life, which give the earliest symptoms of neurovegetative dystonia, determining the nature of his character and its particular pathology, he will never be able to know what he has to cure in the patient, whom he does not know because he is not understood him. So in order to treat any disease, we have to understand the patient, the core of the patient, the personality of the patient, the constitution of the patient. So there is no as such shortcut. So my dear friends, if you are expecting that I'll be sharing some medicinal part, that this particular medicine is very much effective in curing atopic dermatitis. This particular medicine is having an effect on lesions on flagellal surfaces, and so on. So, my dear friends, you are at the wrong place, and I never practiced like this. So, uh, more than that, I would like to share that in today's presentation, I am not speaking something extraordinary. Everything is quite common, quite ordinary, what you have been taught in the graduation, post-graduation lectures. There is no as such shortcut. You have to focus, you have to go into the depth of the patient's mind as well as the psyche and soul of the body. Psyche and mind of the personality and the constitution of a patient. So there is as such no such shortcut. Further, Dr. Ghatak, even he mentioned that man is not an automation like as an engine or a clock. Man is an organism, and any disorder in any part of him is not confined to that part alone, as a disorder or derangement in a clock or an engine. So thus a disorder in any particular part of the man, that is to say a disease, relates to the whole man, and it can be cured only if the whole man is cured. Similarly, even Dr. Vadia has beautifully mentioned that the skin is a mirror on which nature reflects first. Skin is a mirror on which nature reflects first. Certain disorders taking place inside the body. So, actually, there was some disorder inside the body, and the reflections are on the epidermal layer of the skin. So skin diseases can be considered as external manifestations of internal disorders. It is a timely hint for us to find out the cause and treat the original focus. Instead, what we see and find today is that no sooner any eruption appears on the skin, a serious attempt is made to suppress the same. The net result is this, that what nature wanted to throw out and thereby save the internal vital organs, what we do is we suppresses that thing. So there is no point giving external application, say for example liniments, ointments, moisturizers, etc. So there is no point suppressing the itching. But at times, patients are, even you get irritated that what's going on, what's happening, in spite of selecting the quite a very good medicine, in spite of selecting the best so-called similimum, you're not getting the results. So we have to be a little bit patient. Not only we along with our patients should be ready to have some patience in them. Unless and until a patient is having some patience, you won't be able to treat that patient. So moving to miasmatic evaluation, there is ample evidence both in the literature of allopathy as well as homeopathy, which says that the skin disorders are nothing but expressions of disturbance in the internal dynamics, as I said earlier. The cause for this disturbance is invariably a miasm, if we say homeopathically, as it has been put forth by Hahnemann in chronic disease. Atopic dermatitis can be the expression of any of the three miasm and their combinations. It depends upon the different kinds of presentation dermatitis comes up with. The other mistake which we usually do is we start studying miasm from a different angle. We are always in a habit to define a miasm of a disease. For example, we are in a habit of saying eczema is having a psoric miasm. Any sort of ulcerations are having a syphilitic miasms. So, my dear friend, this is wrong. What do you think? Thuja is having only the psychotic miasm behind it. Won't you give any person having any psoric personality Thuja? Just ponder over this thing that no medicine is having a single miasm. I have treated many syphilitic cases with sulfur. I have treated many psoric cases with Thuja. So my dear friends, don't make it a habit to name a miasm to a particular disease. So you will see even even in today's topic of atopic dermatitis, you will see there is a predominance of each miasm. You can see a patient having atopic dermatitis with a psoric miasm, with psychotic miasm, or with syphilitic miasm as well, or maybe a mixture of these things. So Dr. Banerjee explains the miasmatic expressions in a very comprehensive way, in a very easy to understand way. Try to read that particular book sometime. And he mentioned that psora has dermatitis and eruptions of all kinds in which dryness predominates, as you all know. Dermatitis and eruption are papular and associated with itching. Pruritus is always a manifestation of psora. Psoric eruptions are not recognizable by their color, but by the roughness of skin. Similarly, cracks of iron, dry scale, dryness of stuffy and brain-like scales, they all present psora. Moving ahead, having said that, it's a sensation of burning, dryness. The more you wash, the more it gets dry. Itching without pus or discharge is characteristic of psora. The capacity to produce hypersensitivity is psora. In psora, itching often occurs late in evening. It's quite a common symptom. Specifically in, if I say any fungal infection, say tinea cruris, 10 out of 10 people will say that they are having itching at the night time when they start undressing themselves. So it's a quite common thing. Don't take that symptom in during repertorization. Psoric skin complaints are aggravated by cold in winter. Emulsion are from natural discharges. These are quite common things. You all know such things. Similarly, psychotic miasm, papular and vesicular eruptions. Secretions are purulent, painful. They may be localized or in circumscribed spots. Fish scale eruptions are trimismatic, as is mentioned. Thick skin, keloids, warts, cones. So all these things are psychotic, as is mentioned by Dr. Banerjee. And then of course syphilitic. If you get, for example, psoriatic arthritis, if the joints are involved, the flexures of the body are involved, then you term them as syphilitic miasms. Putridity and offensive discharges, we usually take them as a syphilitic indication. These kind of things are helpful in selecting the anti-miasmatic medicine as an intercurrent. So you should not prescribe or you should not define a constitutional medicine based upon the miasm of a disease. But if, for example, in a rash, in a lesion, after a rash, you get a sticky discharge, putrid discharge, acrid discharge, then of course it indicates toward a syphilitic miasm, and for that you will be able to get a clue that if in a later stages, if after giving a constitutional medicine, we have to give any sort of intercurrent remedy or an anti-miasmatic remedy, then it would be a anti-syphilitic medicine. So this particular thing is the main point that we need to understand, that why we define such symptoms as sora, psychotic, and syphilitic. I hope you are with me and you are getting what I am saying. So deep cracks and fissures, again, they are syphilitic. Syphilitic strength is offensive. So these are quite the common thing. We have just 3:45. We have just 10 more minutes, and let me show a couple of cases. Yeah, in a research journal, my article was published, wherein my article was on a clinical study in between July to August 2019, wherein I saw 30 patients in that 1 year, and that was a complete research article wherein we showed that how we collect the data, and we did a cohort study as well for those cases, and then it got published. So therein it was like that in this 1 year, out of 30 patients, 0 to 15 years of age, I saw 17 patients, and 45 and above, I saw just one patient. So this was just showing age incidence in years of those 30 patients. Of course, males were 19, females were 11. The commonest symptoms was itching, then eruptions, then dryness, and then lichenification. Associated complaints, most common associated complaints was cold and coryza, as we see in atopy. Then comes fever, sneezing, cough, constipation, vomiting, etc. Hypersensitivity was quite common. One of the other patient was having any sort of hypersensitivity with either fatty food, egg, wool, milk, fish, alcohol, etc., etc. Past history, yeah. This is a very, very important link between vaccination. So I am in a habit. I always ask my patient what happened after the vaccination, and I usually get a clue that number of patients get XYZ disease or disorder after the act of vaccination. So at that time, you get a clue whether we have to give them a thuja, cilicia, or something like that, or in between or not. Similarly, you will get, of course, you will get some sort of family history in most of the patients. Like in 17 patients, I found that there is a dust allergy in their parents as well, either of the parent, mother or a father, or maybe a brother or maybe a grandfather. I always get maximum time dust allergy is quite a common family history. If we say about miasm, of course, sora is more prominent, then psychosis, then tubercular, then syphilitic. So let's quickly in next 10 minutes, or let's say 15 minutes, I would cover a couple of cases that I cured during my clinical practice. This was a case of a 12-year-old boy, Iran Khan. I have changed the name, of course, of a patient for certain reasons. Patient data is like 12 years, male, of course, not marital, studying 7th class student. religion is Muslim and residing at my area only. So parents came with a male child complaining of recurrent skin eruptions on bilateral cheeks, started on right side and incubated fossa since 1 year of age. So this is important. It's from which was the first patch, how it moved. So it started on right side and incubated fossa since 1 year of age. Parent says he cries with much itching. Erythematous papules, which become exudative, were present on cheeks and subsequently spreading to other parts of body. The lesion involves bilateral cubital and popliteal fossa as well. So this is quite common, isn't it? As I told you, like in childhood, these are the quite common areas of presentation in atopic dermatitis. Skin looking dry, scaly, reddish, unhealthy with much itching, aggravation by scratching and washing, suppressed with local medications. So parents says we took allopathic treatment for so many months with skin specialists, but recurrent eruptions came out again when exposed to sudden changes in atmosphere. They complained of gradual onset of maculopapular eruptions that became erythematous and crusty with time. The eruptions started on right side of cheek and then bilateral cubital and popliteal fossa were involved. They were dry and scaly in nature. He had pruritus with excoriation in folds, which made him cry with much scratching and redness of the affected area. Eruptions were worse by heat of sun, scratching, washing, warmth of bed, night, and better by warm weather. Eruptions were slowly progressing and became severe gradually. So this was the ODP of the disease, of the DP of the patient. He has excoriation in folds, mostly itching worse by warmth of bed, by bathing, and at night. He can't sleep fully, always awake on slightest noise. Physical generals was like appetite was normal, non-vegetarian diet they used to take, quite thirsty, uh, desire for sweets and curd were there. Bowel habits was quite hard stools once in 2 to 3 days. Perspiration, profuse, smelling. So this foul smelling perspiration is one of the factors that I considered. Thermal status was hot, vaccination was done, milestones developed on time. So there was no as such issue with the milestones, with the growth or development of a child. Past history, same type of eruptions were there when he was 2 years. He took allopathic treatment, was got relieved. Uh, his grandmother is having a history of bronchial asthma, hypothyroidism, diabetes mellitus. His mother was having asthmatic episode when exposed to dust, pollen, damp, wet weather since 3 years. So you see, family history is quite common in such cases, especially any sort of atopy. When I asked about the mental or lifespan of that particular that Iran Khan, I found that he was full-term normal daily weight. At birth, he was having 3 kg of weight and is lean thin since then. Skin affection with hereditary history. Mother complains that though he has good appetite, takes sweets, milk and food, but not having strength in body. His mother also said he has much heat in body and is hot when touched. He wants cool and open air. History of all milestones delayed. He has dullness, sadness, and shrunken face. History of worms were there. He became restless and sleepless due to itching. He kicks off clothes and covering at night. Mischievous, talkative, destructive, breaks the toys, cruel, chews clothes, angry on triples, and beats everyone. So Mazen here, fundamental of course was Sora. but the dominating miasm here is syphilitic one. Why so? Anger on trifles and beats everyone. Destructive, breaks the toys, cruel, chews clothes. So, so of course, these are not at all the physical symptoms, but you definitely get a clue that, of course, this child, the dominating miasm here is syphilitic one. So our medicine should be, a syphilitic one that covers the entire totality of the symptoms. So I took these symptoms as a totality: skin eruptions with itching, worse by scratching, washing, warmth, night and heat, ailments from suppressed skin eruptions, desires for sweets, constipation with hard stools. He was a hot patient, sleeps uncovered, sleep short, lean, thin, odd looking with dullness, and of course, mischievous, talkative, destructive, angry on trifles, and beats everyone. So, any guesses? Yeah, Ayushi has mentioned Madurai. Okay. Any other guess? Now, can you just guess the remedy after the repatriation? Graphitis. Yeah, Krishna Arjuna, you are quite near to the medicine, but uh, there is something different medicine, but you are very much near to that particular medicine. Sina, no. Dr. Neeraj, sulfur, no, of course not. Sulfur is having quite a destructive personality, which sulfur is not. Tuberculinum, no, Yashika. Sulfur, hyoscyamus. Okay. Uh, Petroleum, Meserium. Dr. Utpal, may I know how you are guessing Meserium, whereas others are guessing sulfur, calcarea carb, chamomilla, etc. Waiting for your answer, Dr. Utpal. Yeah, Dr. Utpal, would like to get your views. I mean, how you are selecting Meserium? Why Meserium? Even though Meserium here is on number 5th. Yes, Dr. Utpal, you are right. The medicine I prescribed here was Meserium 30 TDS for 15 days. Why Meserium? Because when we get to see that the repertorization table, what we found is sulfur, murk, arsenic, calcarea. But the distinguishing feature was the perspiration, the offensiveness. Let me take it back. Perspiration, profuse, foul smelling perspiration. Profuse perspiration is there in murk as well, but foul smelling perspiration is there in Meserium only. So physical history at times helps you in selecting a particular medicine. So I prescribed him Meserium 30 TDS for 15 days. Now somebody might ask that why not a single dose? Why thrice a day, that too for 15 days? So my dear friends, in such cases, we usually see that unless and until you get to see I'm in a habit of repeating the medicine until I see some sort of improvement. So I prescribed him twice a day for 15 days. After 15 days, eruptions on skin was better, but itching on arms was present. And later on, reddish, so this was the first time that eruptions on skin was better, and then reddish papular eruptions were there. So I prescribed, since he was better, I prescribed him SL. Status was same. As an anti-miasmatic, I gave him sulfur 1 m. Then on 28th of December, itching disappeared, but dark black pigmentation on skin was there. This post left after eczema. Measuring 30, now OD for alternate days, for 15 days. Patient felt better. Then erythema decreased, better pigmentation, minimum. Pigmentation was minimum, no aggravation. Even in winter, that was an important point. From all this, I would say 19th of January to last prescription, he was been prescribed SL only, and I followed up after 2 years for 2 years, and there is as such no such relapse even till now. Even he is still my patient. His family and his entire family is in touch with me, and touch wood, he is far better. So this was the result. At times when he came to me, he was so itching. He was in a habit of applying the moisturizer. You can see the glass, you can see the glare. So this was due to moisturizer. And after our treatment, these were the patches. There was a marked improvement without any relapse. Yashika, it's 4. Can I take fastly within 5 minutes one more case, or Shikar is waiting?
As you wish, sir. We'll have a question answer session also for 5 to 10 minutes.
Okay. So I think
no problem, sir. Continue. Please take the cases.
I'll go fast. Within 5 minutes, I'll finish it off. So,
sure, no hurry.
This was a case of a 3-year-old child. He was having all such complaints: recurrent redness, vesicular papular eruptions on face, scratching, aggravation, winter. ODP was since 4 to 5 days of age. Patient started having erythematous eruptions on both cheeks, and then it was relieved by applying external ointment. Nothing was important. Asthma was associated. Bronchi was there. Patient was chilly. Constipation was there. You can just easily guess this remedy. Perspiration was profuse overhead, especially at night. Chilly patient, constipation, talks during sleep of daily events, sleeps on abdomen, fair, flabby, sluggish. I hope you'll get the medicine with this only. Delayed talking was there. So my dear friends, delayed talking, fair and flabby child, chilly patient, profuse overhead perspiration, especially at night, constipation. Yeah, calcaria. Everyone leads to one remedy. So you can see everybody is up to calcaria only. Why? Why? Because you all know calcaria. So my dear friend, if you take a case in a right direction, if the case taking is perfect, each and every doctor will prescribe this guy calcaria. So what we have to focus on is the case taking. So I prescribed him calcaria carb. These were all the other things, past history and all, family history. There was a mental, of course, mischievous, jolly nature, understanding nature, fearful, also point towards calcaria. Fear when alone, mild, weeps easily, quite sensitive as calcaria is. This was the totality of symptoms that I took, and after repertorization, it comes to calcaria only. I prescribed him calcaria cup 30 OD for 15 days. Once I prescribed him tuberculinum as an intercurrent, as an anti-miasmatic medicine, 1 single dose. This particular patient, I prescribed just 1 single dose, calcaria cup 31 dose every day for 15 days till he get relieved. So this was the result. At time when he came to me, he was having the extensive rashes all over his face. You can very well, imagine that how this particular boy, this sweet boy, was, living. He was his parents was in a habit of applying moisturizer, ointments on a daily basis. So you can see how our homeopathic medicines work like magic. Of course, these two cases of atopic dermatitis elaborated in the presentation opted for homeopathic treatment as second choice after relapse and remissions. So these cases suggest that homeopathic treatment could be regarded as an effective choice for patients with AD. It is important for all of us to work more meticulously on modern scientific parameters, creating enough documented proofs as per the need of the hour, without jeopardizing the tenets of homeopathy. So our studies have no gaps with such analysis was repeated. So thank you. Thanks a lot. Over to Yashika.
Thank you so much, sir. There is a question on YouTube from Dr. Sandhya. Chronic cases of skin diseases. How can we prescribe the dose? Yeah, how to decide the dose of the
See,
case?
actually, it depends upon the case to case. When you are focusing on the totality of the patient, and when the totality is of both the physical as well as mental symptoms, then the potency can be different. And when you are prescribing only on the mentals, then what I usually do is, for example, if all the physical symptoms, all the physical general symptoms are quite common to the disease, and I get a typical personality based upon the mind symptoms alone, I usually give high dose when I prescribe on the mentals only. But when I combine particular patient is having so many rashes, so I can't take a chance with a single dose. So I usually in a habit, I'm in a usually in a habit of prescribing say twice or thrice a day, maybe up to 15 days, as we see in the last patient. And till that time, when the patient is somewhat better, somewhat, if the patient's parents says that now he's quite better, now he's having little bit of rashes, now the rashes are bearable. Till that time, I keep on repeating the medicine. Next.
Thank you so much, sir. There was a question for the potency. What was the potency used in the
Maximum
second case? In the second case.
criteria property. Criteria
There's a,
property.
yes, sir. There's a question: how frequently intercurrent should be given in chronic cases of AD?
Intercurrent should not be given to very much frequently. Intercurrent means intercurrent. That means we'll have to prescribe the intercurrent remedies only when your indicated remedies stop acting. When you see that Calcarea carb is not functioning anymore, and you are pretty sure that Calcarea carb is the one and the only similimum, it's the best indicated medicine as per your understanding, then you have to prescribe the intercurrent remedy to enhance the action of Calcarea carb. After the action of intercurrent remedy subsides, then you'll have to prescribe this Calcarea carb for example again, and then it will work like magic.
Sir, there was a question if for the first case from Dr. Ayushi why Miserium was prescribed again, and Dr. Shreya wants to know why didn't you increase the potency to 200?
Yeah, see, first of all, she asked about why Meserium. Number one, when we saw the repertorization sheet, there was, and when we recollect the symptoms, there was an offensive discharge, there was a hard stools, miasm was syphilite, there was an anger on trifles, and the direction was right to left. If we go to the last slide of repertorization, so all these things lead to mesothelium only. So that's why I prescribed mesothelium. And what was the next question, Shika?
Sir, the potency.
Potency. Why not 200?
Yes, sir. Why didn't you increase to 200?
When 30 was working, what's the point of increasing the 200 potency? We prescribed mesothelium 30 for 15 days, and after the first follow-up of 15 days, the patient was quite better. But at that time, when we found that on 4th of December, say after 3 months of Calcarea carb, when the action subsides, I gave intercurrent remedy. After that, intercurrent Nazirium helped. So why to raise the potency when it's working?
Thank you so much, sir. From Dr. Gauri Nandana, there is a question: is allergy intolerance of mind like psychic causes of dermatitis?
Yes, it can be. We can't ignore this. You are pretty right. You are quite right that allergy can be is allergy intolerance of mind. Yes, it can be an intolerance because as is mentioned in my very first few slides, that only you can't define any particular disease with the superficial layer. There is something deep, but the topic of my presentation was this only.
Thank you, sir. Sir, there is a question on YouTube: when to prescribe anti-miasmatic remedy during the course of treatment when we are giving the constitutional treatment to the patient?
When the action of your constitution remedy subsides, when you find that now that particular constitution remedy is not working anymore, then you have to give any sort of either intercurrent remedy or anti-miasmatic remedy to enhance the action of your first, you know, first prescription, first medicine. I think it's quite late now. I think Sheetal must be
Yes,
waiting.
sir. So I just want to request you to please type in your email ID in the chat box so that people can mail you the queries if you have any if they have any queries.
Yeah,
So
sure. Bidani@gmail.com. Anyone can write anything about this, and I'll try to solve all these things.
thank you so much, sir. So I want, on behalf of my whole team of Homeopathy 360, I want to thank you, sir, for your contribution as well as wonderful explanation on atopic dermatitis and contributing to this webinar series on behalf of Homeopathy 360 as well as Asha Homeopathic Academy and the Homeopathic Key. So thank you so much, sir, for sparing out your valuable time for the series. Thank you so much. So now
Okay.
without wasting any more time, I should hand over the session to Dr. Sheetal. She'll be taking she'll be discussing on the growth and development. So, ma'am, I hope you are with us. So we hand over the session to you. I request the audience to please mail the queries if you have any queries left to Dr. Bidani, sir, or you can mail me at webinar@homeopathy360.com. So we'll start with the session of Dr. Sheetal. Ma'am, uh, please begin the session. Over to you.
Thanks, Yashika. Um, that was a very insightful session by Dr. Bidani, and I think he has covered a lot of points which is important for our practice, and especially with the dosage and more than what a person can ask for. He had given it in a very good session. So today, my topic, what I will be discussing today would be. I know that we have a lot of doctors and students joining in. So a little bit of revision, or a little bit of what we had learned in our basics of our UG or during my PG. I would learn this. So I wanted to share this with all of y'all so that it becomes easy for us to understand the normalcy in the practice. So, having said that, in homeopathy, we know that we take every child as a unique individual, and we give utmost importance to the individualization of every child, no matter if he's in the same age group. We always individualize the case and respect or adore the uniqueness of each child, so that we come to a right simillimum. So to actually understand the uniqueness of a particular child, we need to know what is the stages what a child goes through, what is the normal stage for normal levels, like how we give more importance to the uncommon symptoms or the peculiar PQRS symptoms, because we wouldn't consider that the diagnostic symptoms are not so important in the resultant of the simillimum. We give so much importance to that because we know what is common to the disease, common to the person. So once we get to know what is common or what is normal to the child, we can pick up things where which can be peculiar, unique, which will lead us to the simillimum. So today's session would be more towards learning the basics and getting to know what the actual growth and development period what a child goes through. And so growth, what exactly is growth? Growth is a physical maturation. So there is an increase in the size of the body of the various parts. So there is a physical multiplication of cells takes place, where there's an increase in the intracellular substance. And this is a more of a quantitative changes of the body. So this is a quantitative entity of the body, whereas development is more of a functional, a physiological maturation. So the individual, once he's developing further and giving these functionality to whatever has been quantified, growth is the cells are increasing or the multiplying. So once they have grown well, there is a function that each of them have. Like each organ, once it's there, having grown as an organ, it has to have its own function and reach to that physical maturation, so that it can take place the normal functioning of the particular organ. So this is related to the maturation and the myelination of the nervous system. So this includes all the psychological, emotional, social changes, and it becomes the most of the qualitative aspect of the child. So that is the major difference between growth and development. But the growth and development in a human being has a particular principle. It goes according to a certain pattern that goes through and through between every individual. So this has been followed. Every child has to go through this kind of principle. So first thing is the cephalocaudal direction, proximo-distal direction, and the general to specific. This is the major principle. So what is cephalocaudal? Top to bottom. So like how Herring tells us, right? If anything, this is actually because the growth itself takes us closer to our homeopathic principle also. So having said that cephalocaudal is head to toe, top to bottom. So first the head is developed and then the other parts get developed. So first in the development, in the embryonic stage, there is the neural tube that is developed first, and then it is then the rest of the body parts get developed. And proximal distal, so from center to the outward, just like how Herring also said that whatever happens in center to outward. So that is the way of its growth. And general to specific, what do I mean by general to specific? If you see a child, if it is a baby, it'll first, if you give him something to have, they'll first grab it. It's totally a grab scenario. But after a period of time, it gets more specific. If you ask him to take 2, 3, 4 things first time, he'll take all the 3 things together. But over a period of time, once the development is taking place, if you ask him to take one from that, he will be able to take one specific thing also. So the growth becomes more, when the cognitive development is taking place, then things will get easier and more specific in the growth, basically. So what are the factors that influence growth and development? So growth and development, obviously all human beings have a varying type of their growth or their development. Some have a good height, some have a low height. So all these things depend on the various factors that a person can portray. So one of them being the genetic factors. What are the genetic factors? So when we're talking about genetic factors, it is what is a race, what is a predisposition, what do they inherit, how they are, what they're subjected to. More so, if parents are tendency to have lifestyle disorders, they tend to have children with some kind of a problem, or they might, let's say for example, there is diabetes and hypertension in the family, and with the child can have a tendency, that's a predisposition to have it later on in his life. So even the sex matters. Some are very predominant to the females, some are very predominant to the males. And race and nationality, which area they are living in, what kind of food they eat. And the India is a more tropical center, so we will see more of infections or cholera or things more prominent in India. So nationality becomes more important here. So what are the prenatal factors? Prenatal factors are the impact and environment is an important predominant factor of growth and development. And what are these conditions have a direct influence on the fetal growth. Now, maternal malnutrition. Maternal malnutrition becomes very predominant. Like we have seen, our parents being told to have food and care of the body during the pregnancy. How do you why is it so important? So not just that, studies have also shown that maternal's own fetal, even when her childhood growth, how her diet was, even in the childhood time, and how she has taken care of her body during the pregnancy also. So all of that play an important role in determining the whole lifelong well-being of her child. So that becomes very important. So also, like if it is a teenage pregnancy, if it is if the mother is subject to tobacco or substance abuse, or she's going through some kind of an infection during pregnancy, so the child has a direct effect on its growth and development. And next is the hormones. Hormones play an important role. Like for example, the normal development cannot happen without the kind of right balance in the hormones that the body is requiring. For example, the growth hormone, the thyroxine hormone, or the cortisol hormone. So if there is a up and down, or if there's an absence of all of this, you get things like dwarfism, or lack of syndrome. So all these things start affecting directly. Or if we have to think about the other causes, like the socio-economic level, how they are subjected to the various environment what they are living in. So that becomes also very, very important. So other miscellaneous could be even some medications what they are taking during pregnancy, and the chemical agents, like if there are any trauma or any problems during pregnancy. Trauma being not just a physical but also an emotional, all these things become a very important factor in the growth and development of the child. Having said that, and even the postnatal factor. So now, what is growth potential? Growth potential is how the child can grow. Like how much can he grow? Like is there a genetic predisposition for this particular kind of growth? If there's let's say for example, the kind of velocity it is going from the starting to end is following a good pattern, if it's going according to the norms what it's given in the growth chart. So all of these become important. Postnatal also, nutrition of the child becomes important. If the child is going through some childhood illness, physical environment, which I already told of, even the psychological environment, which becomes so important. Even if there is an emotional, a lacking when the child, for example, if you take an orphan child, if there's an emotional lacunae, there's a there are different syndromes which can lead into, and the child will also get that emotional deprivation, and that is one of the major part of our mental nutrition. So that becomes also important. Socioeconomic status and climate and season, because there's a tendency, like if in during the time of spring or hot season, some children have a tendency to put on more weight. So things like that. And if the child is actually having some kind of physical activity, indulging in play and exercise, birth order of the child means that which when was the child born. So if it's the first born child, it's the birth order is 1. If the second born child, the birth order is 2. So usually you see the first born child is completely given over care and over nourishment, and they might overfeed also. Or if the second born child is there, the firstborn is all is neglected or feels neglected. So at that moment, there is a probably hampering the growth and development of that child. And again, hormonal influence becomes very important. Especially this happens during the first year of the life and during the growth spurt that happens during the puberty. So just understand what are the periods of growth in a child. So from ovum, if we start during the prenatal, that's the first 15 days is what we say is the ovum. Once it has got fertilization is taken place, it's an embryo, and till 9 weeks it's called an embryo. Once it develops into a fetus, till birth, from 9 weeks to birth, it develops into a fetus, and that period, the first prenatal period is called the 22 weeks of gestation to the 7 days after birth. So once the baby is born, it's a newborn until the first 4 weeks, and during the whole of first year, it's called the infancy period. And the 1 to 3 years old, they are the toddler age group, and preschoolers are obviously when they're going to the preschool, so 3 to 6 years, and school age child would be from 6 to 12 years. Once the early adolescence sets in is the 10 to 13 years of age, and middle adolescence is 14 to 16, and late adolescence can be from 7 to 20. So we have different terminologies what each period of growth takes place, depending on the type of growth the child is going through. Now, there are certain laws of growth. Coming to growth, so let's first focus on what is growth. So since we've already discussed that growth is nothing but the multiplication of cells, where the cells are increasing in size. So just a revision from what we said, the cells are increasing in size. So now there are different laws in which the growth takes place. So the growth and development of the children is a continuous and an orderly process. So now what happens is there are specific periods in the child's life. So there's a steady state, there's an accelerated state, and there's again a decelerated state. So for the first year of the life, the child grows rapidly. So if you can see, every other day the child is growing, and every day the child is either putting on weight or increasing in the height. So there's a fast-paced growth in the first year. Then there's a steady phase, and then again during the puberty there is growth spurt takes place, and there is the development becomes accelerated, and then again it starts decelerating. So it follows a pattern like this, which is an orderly process, and that is how this is one of the law what growth follows. Now, what happens in the second one is growth pattern if every individual is unique. So this, I think all homeopaths are respect this factor really well, because every individual, yes, it does follow the cephalocaudal, yes, it does follow the proximo-distal kind of principle, yes, it does follow general to specific, but it is unique. So it could have happened that during the fetal life, growth of the head will come first. All these things are normal, but the individual is unique in itself. How they grow up to be, that is something which takes place. So now, also unique here, I mean that within the fetus, when the fetus is within the womb, it says that it is said that it has to grow from from the fetus to first the anatomy is done, then the physiology is done. So there's a way of doing it. And later on, once the child is born, it will start, crawling or, start walking. So that is the way, that is a uniqueness of the growth. But it's not going to happen vice versa. Until and unless this order is followed, then it is not the kind of growth. This is the one law of growth again. So now the next and the most important is the different patterns. There are different patterns in the body that grow at different rates. So to understand that, I will show you this graph where each part where we are understanding that each, let's say for example, we're talking about the brain growth. So we're talking in the years. So the first years, till the first 2 years, the first 2 years are very important because the child attains its 90% of the adult brain growth by the second year. So that is why people take care so much that the child is doing well and taken care of during the first 2 years of life, because that, if it is not done properly, it's a long-term issue. So that is why the first thing becomes first 2 years become very important. That is a brain growth. Now, for example, for the other thing is the gonad. We know that gonadal growth is dormant during the childhood, and it becomes faster and faster during the puberty period. So if you stick the gonadal growth, it doesn't start until it is in the 12th year or 13th year of each child. So that is about gonadal growth. Now, what about the lymphoid growth? So the lymphoid growth it's very seen that during the mid childhood, from let's say the toddler age group to the preschool age group, that is the peak of lymphoid growth. So it slowly starts off, but the peak is the mid childhood. And during this period, you can see that there is a lot of overgrown of the lymphoid tissues, and that is why you will see it. You see children of that age group, let's say from 4 to 8 years, they generally have this tendency, or they have enlargement of tonsils and palpable lymph nodes around the cervical region. So that is something which is common. It is common, and it is the period where it is a period where the lymphoid growth is at the peak, and that is why the enlargement is taking place. That is why there is tonsil enlargement. So when it is leading to tonsillitis and there's inflammation, there's pain, then we can give the treatment. But this is the period where there might be palpable lymph nodes, there might be enlargements. That is nothing but the way of how the growth takes place. Now, to understand normal growth, we need to have different parameters. So every individual might have their own way of growth, but these are certain parameters which we can follow to understand what is normal. So we have weight, length or height. Length, because the infancy period we treated like we measure the height in length format with the in the supine position, and head circumference, chest circumference, mid-arm circumference, BMI, eruption of teeth, all of these become an important factor to understand the normal growth. Now let's say weight. Let's start off with weight. So the weight, an average child having usually has a 3 kg of average Indian child basically. So he usually is having 3 kgs of at birth weight is 3 kgs. So by the time he's 6 months, there is a double. 6 to 5 months, it doubles in its self, and by the time it's 1 year, it triples. So what happens is, from the birth, the child starts. This is the period where the child is accelerated. The growth is accelerated, and that is why the child's weight is doubling in the 6 months period of time. So at that moment, initial 10 days, now birth weight being 3 kgs, after 10 days, the first few days after birth, the newborn will lose about 10% of the extracellular fluid. So there might be a little loss in the first few days. Nothing to worry. It will gain back, and most of them will gain back in in the matter of few days. So what happens in the first 3 months is that the child puts on weight at the rate of 25 to 30 grams per day for the first 3 months, and then almost every month the child grows almost 400 to 500 grams, and that is why by the first birthday it triples its birth weight. And how do we keep seeing the expected weight? At the 5th year, the birth weight can be multiplied by 6, at 7th by 7, at 10 by 10. So on an average, a child gains about 2 kgs every year between the ages 3 to 7, and 3 kgs every year till the pubertal spurt begins. So this becomes important because commonly in the clinics, what do people ask? Like, is my child putting on enough weight? Is a child optimal to his height? Is a child optimal to his age? So that is why understanding the birth weight and the actual estimated target or expected weight for that age becomes very important. Now, what about the height? So if we say the height, so in the height period, we have usually at birth, children are at 50 centimeters on average. If a 3 kg average baby is born, usually they are almost 50 centimeters. And the infant puts on weight, puts on the height at the rate of almost 5 to 10 centimeters per so by first year, it's almost 75 centimeters, and then so on. So to understand what is the target height, we can utilize it. Now every child is unique again. We cannot, so in school the height order goes on because we have to follow the rule, right? Similarly, it depends on how the parents were, how the parents' height is. If the parents' height is expected to be high and the child is having a short stature, that time we can calculate it. So best way to understand is that the target height could be calculated in these ways. So the father's height plus mother's height in centimeters divided by 2 plus or minus 6.5. That is for boys plus and girls 6. So this is it's a very useful guide because for the normal range, the target height will be utilized with this particular formula, plus in the range of plus 6-7 centimeters for girls and minus plus 8.5 centimeters for boys. So in this way, we can talk to our patients if the child is on optimal level of height, and because it becomes more specific to their genetics, to their well-being, on how they have been brought up. So another important thing here is the head circumference. So head circumference is calculated, and in the first year, there is a lot of rapid growth. Like I told you earlier, the child develops almost 90% of the adult brain growth by the second year. So during the first half of infancy, the head is always molding and it's growing very rapidly. So this also reflects the brain growth, what I was talking about. So head growth slowly, it comes down after a period of time. So once the brain growth is attained, then the growth starts decelerating and not be of the same type. Now, fontanelles these are the sutures in the skull which are open during the birth. So at the birth, the anterior and the posterior fontanelle are usually present, and the posterior fontanelle closes very earlier to few weeks of age, and anterior fontanelle normally closes by 12 to 18 months. So the first thing is posterior fontanelle closes within a few weeks, and then by probably 1 to 1.5 years of age, the anterior fontanelle slowly closes, depending on once the brain growth has occurred. So now what happens when there's an early closure of the sutures? There's a condition called as a craniosynostosis. That means the premature closure of skull. This is important because if the brain growth has not occurred so well in children, we can understand it, like if there's microcephaly, if there is any deformity in the head. So this becomes an important clue if the fontanelle have been closed in earlier in that particular child. Now chest circumference is also measured, and chest circumference is usually So it is usually 3 centimeters lesser than the head circumference at the birth. So once child is of 1 year of age, the head circumference and the chest circumference become equal, and thereafter the chest circumference is always exceeding the head circumference. So the mid-arm circumference is also a very important, marker for the growth of a child, because it helps in understanding the nutritional status of the younger child. So it is the upper arm, the mid-arm circumference what it's taken. This is a specific tape that is used. It's called Shakir's tape, where it becomes it's got its own gradation like green, yellow, and red, and it helps us to understand if the child is going into malnutrition or over nutrition. So the average is 11 to 12 centimeters at birth, and at 1 year of age it is 12 to 16, 1 to 5 years 16 to 17, and 12 years it is 17 to 18 centimeters, and 15 years is 20 or 21 centimeters. This becomes important especially in the cases of protein energy malnutrition, or you've seen different places where the children have not been given enough proper nutrition because of their status or poverty or deprivation. So this becomes important pointer to understand. Now BMI, I think we all know, so that is weight in kgs divided by height in meters square. This becomes important again to assess the normal growth and any deviation from the normal growth. So if it is more than 30 kgs per meter square, it indicates obesity, and if it is less than 15 kg per meter square, it indicates malnutrition. So this is the categories of BMI. So if it is less than 18 kgs, 18.5, it is underweight. If it is more than 30, it is obesity. And normal weight lies somewhere between 18.5 to 24.9. So in children, what else is important? Like if you ask a child, obviously the parent also will know, want to know when will my child's tooth start erupting. So the first tooth that comes is the lower central incisors of the mandibular central incisors. So that starts off from 5 to 7 months of age. That's when they start having all the dentitional issues and all that. So you have an idea that the 5th, 7th month, once the dentition is started, you have to be aware of that particular next milestone of this child. So to know this thing, so central incisors come first, that is a mandibular, then the lateral come in, then again the central incisors on the top come in, then the lateral incisors of the maxillary come in, and then canines come in only by 16 to 20 months. Before that, we have the first molars that come 16 to probably 1 to 1.5 years time, and then we have the second molars that come later on after the second year of life, 1.5 years of life. So that is a primary teeth. That is the eruption. So the first molars, after they've fallen, by 6 years the child is getting the first molars, and by 7 to 8 years they're getting the central and the lateral incisors. That is when they are in the first, second standard, they're losing their teeth, and then they're again getting the eruption of the teeth. And the canines and the premolars only by 9 to 13 years, and second molars by 12 years, and the third molars that also was wisdom tooth, all that comes after 18 to 20 years. So now, what are the disorders of growth? Now, disorders of growth becomes important for us. So once we know all the normalcy, what is a normal child growing like? What are the parameters that it's checking? Is it checking for a proper height, proper weight, proper head circumference, chest circumference? Is it appropriate for that particular age group? Then, if any deviations are there, then we can go for understanding the disorders of health. So failure to thrive is nothing but between below 5 years of age, if the child is not able to put on the optimal growth levels, that is when. So we have different growth charts. Growth charts actually help us to understand what where the child is lying, if the child is correct to the height or correct to the weight. So that becomes important for us to understand. So failure to thrive is nothing but when the child is not able to put on weight. This is usually seen in below 5 years of age. So that is failure to thrive. So this is not a more than a diagnosis. It is more of an understanding how the child is, and usually it is seen up to 5 years of age, and the physical growth is less than, if you compare the child to the other one, it is quite less than the other things, and it doesn't reach the normal percentiles in the growth chart. So similarly, short stature is when the height is defined as the height is below the, if we have the 98th percentile and third percentile being the lower range, if it is below the lower range of the normal range of a good height, that is when it is called the short stature. So the median age and for the median height for that particular age and sex is not matched, and then it is lower than that, then short stature can be. There are many causes to it. So, but we have to understand if it is a constitutional delay or if it is a familial short stature also. So, depending on, like how I said, the previous parameters, we have to understand. Same thing comes with tall stature, where if there's too much of growth hormone or there's any a hormonal imbalance can lead to tall stature. And I already told you about craniosynostosis that indicates the brain growth. So if the brain growth is not taken place well, obviously think about craniosynostosis, where the sutures are fused very early. And one of the most important things in the current scenario is childhood obesity. So it's the lifestyle what the parents are leading, and the over care or love for the children. What I'm seeing in the clinic also, they're stuffing the child. Even if this child is okay, is enough, and they are they force the child, or the child itself doesn't know where when to stop. The satiety hormone is hampered. So childhood obesity is rampant because, again, there is lack of play, exercise, and the kind of lifestyle and the junk food what they're eating, and the impact of hormonal imbalance. Even if there's there's a very rampant diagnosis of Cushing syndrome that is coming because of high levels of androgen. So we can think of all of this. So we are able to diagnose and come to a conclusion. Unless we don't know the normalcy, it becomes very difficult. So coming to the development part, now development is, like I already said, it is more of the maturation and deals with the myelination of the neurons. So how do we analyze this? So we have different domains where we can analyze the development part, whether it's gross motor, fine motor, if it is personal and social development or the general understanding of the child, what is the language and the vision and hearing. So all of these domains, once we see in different areas, we are able to understand the child is developing in the optimal level for his particular age group. So now let's say gross motor, we know that there are certain milestones which we usually ask. So any case we take of a child, we need to know if the milestones are right. So unless we know what is a normal milestone, we won't know what is the deviation of it. So the first thing said that motor development progress is an orderly sequence, and the ultimate attainment of locomotion and more complex motor tasks thereafter. So the aim of gross motor development is locomotion and to be able to do major tasks, the other greater tasks what a human is required to do. So first thing is that if they are able to lift up their head. So the first one of the important thing is the neck holding. So neck holding comes in from the 4th to 5th month, and once you're able to pull up the child to sit, the newborn's head will lag behind, but once it's 4 months, it will start coming. So in ventral suspension also, you can see here that the child is unable to hold the neck in line with the trunk, but by the time it is almost 8 to 10 weeks, it's able to hold the thing in the line of the trunk. The next thing comes the ventral suspension, where by 4th month it is able to hold the head exactly in line. Otherwise, it will lag, it will fall forward. And in the prone position, it can try to lift up the face also. And over a period of time, they can put their heads off, and after again by 6 months, they're able to get the chest up the body in the prone situation, in the prone position. And for sitting, by first with support they are able to sit, and there's a curvature in the back. they're not able to make it straight. So then later on, the back becomes more straighter after it's attained the neck holding done. Once the neck holding is done, the back can get straightened. So that is after 4th month. Then comes the sitting. First, the child will sit with hands in front. By 6 months, this is called the tripod position. And then it will start sitting without position by 7 to 8 months. And by the time it's almost 8 to 7 months, it can start slowly stand with some kind of weight. And by I think 1 year to 1.5 one year few months, it can stand without balance also. So overall, first thing we have to know is neck holding by 3 months, rolls over by 5th month, and like I showed you the photo, sits in the tripod position with its own hands position by 6 months. By 8 months, sitting without support. By 9th month, standing on holding with support. By the first birthday, the child is sleeping well, it's walking well, walking but still falls, and it can stand without the support. And by 15th month, it is able to walk alone and go upstairs also. And that 1.5 years later, the child is running and exploring everything in the house, can go up and down the stairs by 2 years, and by 3rd year, it's doing all the shenanigans what it's supposed to do. So that is a brief about the gross motor development. And moving on to the fine motor development. The fine motor development is again maturation of the neural tract. In fact, because this promotes the adaptive effect, development. It promotes adaptive actives of with fine sensory adjustments, including the hand and eye coordination, hand and mouth coordination, or the skills of the hand, the thumb opposition, or the grasping, or the buttoning, and all these things become the fine motor development. So main thing what we have to see when we ask in the clinic are the hand and eye coordination, hand to mouth coordination, and the advanced hand skills. So if you see a child when the new few weeks after it's born, it's already seeing its hand and admiring what exactly it is. It's already able to see something which is closer to the face in the first few weeks also. But once you start giving something, like let's say on the cradle you have some games on top like this, they're able to grasp it with both the hands. This is called the bidextrous hand. So like I told you, more general to specific. So first thing is general, with it'll start holding on to objects which is with both the hands. Then slowly it will develop a more mature grasp. So first there is an immature grasp where there is more, it will hold it from here. So it will hold more on the palmar grasp. And then there is a slow development where you start using the fingers, but it is more towards the ulnar side. And then again later it will develop towards the radial side, and slowly it goes into the pincer grasp. So that again, this is the pincer grasp, which comes on by almost 9 to 10 months time, or even by 1 year it takes no issues. So by 15th month, by 1.5 years, the child is already ready to start scribbling on the doors and everywhere. So this is the by 15th month or 1.5 years. So overall, by 4th month, they are able to grasp with both the hands. They're reaching out for objects, and then by 6 months, they're able to take it with one hand. And by 9 months, they are at least able to start their pincer grasp, but not so mature. By 1 year, they're able to hold, with just the first 2 fingers and have that proper pincer grasp. And by 15 months, I told you they're able to, start scribbling everywhere. And when you give these blocks for them to, do it, over a period of time, they're able to make different towers. By 2 years, they're able to make a good vertical tower, and starts able to copy. That's why it takes at least 3 years or 4 years for you to start putting the child to the school, because once the copying starts, like if you show how to write, let's say a plus or a cross or a triangle, they can start copying once they are 4 years or 5 years of age. So next thing is one of the most important, and it is very easily seen, the personal and the social development, where social and the cultural situations show how the neuromotor maturity is taking place. So this is more of the interpersonal and skills and social skills. So let's say like social smile and recognition of mother, and when something is given to it, how it reacts. So all of that takes place. So first thing is, adapting is the first. When you see the mother or somebody smiles to the child, it smiles. So this social smile starts from the second month, but this has to be differentiated from something called as the spontaneous smile. So spontaneous smile is when the child smiles even without a stimulus. So social smile comes when somebody else is actually triggering, and then we have the social smile. So it by third month, it's able to recognize the mother and knows that it's going to get the feed and anticipates it. And by 6 months, it recognizes the strangers, and that's when the stranger anxiety starts. When when if the known faces are not there or the mother is not there, the child might get a bit anxious. And by 9 months, they're already waving bye bye. And by 1 year, and the child is responding to the name and plays some simple ball game when it is advised. So by 18 months, it's already copying the parents, and that is when why we pretend play starts. When 1.5 year to 2 years, whatever they see at home, they try to copy it. So that becomes very important. So by second year, they're able to tell they are hungry. They'll ask food and they'll drink, and try to be with the toys. So they are getting to know more. By third year, they're sharing their toys. They know their name, they know their gender. And by fourth year, once they're in school, they're able to play with the group, go to the toilet also alone. And that's when by third year, you can start training. The toilet training can be started. So by 5 years, it can do small. The child can do small activities at home, and also starts buttoning and unbuttoning. First they learn how to remove their clothes, and then slowly they learn how to start buttoning. So these are the normal things. So for language, what happens is by first year, first year, that the few words start coming by the first year of development. By 1.5 year, they have more than 8 words in their vocabulary. But until then, it's usually the cooing and a few words like ba and da and pa. They make more sounds until they're 6 months. So only after the first year, you will start getting those small words where it's actually meaningful. So by the end of third year to fourth year, they're able to narrate a story also. So they'll ask, and they start knowing more words in their vocabulary. So overall gist of whatever development we have gone through so far is, in 1 month, the baby is still neck hold, still responding, and having able to see the hands but not doing much. And by second month, it's trying to give a social smile. By third month, it's able to reach out to things with both the hands. And then by fourth month, it can roll over. And by fifth month, also fourth to fifth month, they are able to roll over. And 6 months, they're already having some baba and papa, and they're trying to sit up and try to crawl. And by 8 months, they're sitting by themselves. And by 9th month, they're crawling upstairs. And by 10th month, they're standing with some kind of support. And by 12 months, they are able to even say mama, papa, and again walk without any support. So that's a gist overall. I think I'm running out of time, but Yashika, there's time, or can I continue?
It's okay. We have an hour to expire, but you can take it. Okay.
Another 5 to 10 minutes, I'll just wind it up, because I think this is disorders of development, and then we can do a little bit of homeopathic part, so that we know what we can use it. So having
All right, it's all right.
Okay, done. So that is the overview of the growth and the development part of a pediatric age group or a child. So we have learned the normalcies here. So now it becomes our the main thing for us is the treatment part of all the abnormal things that comes across. So once the abnormal things come, that is when we are able to pick up all these abnormal disorders of development once we know what is normal again. So behavioral disorders being one of the most important ones which we see day in and day out in our practice, with the utility of so much of technology, and parents being busy and not being able to take care of their children, and or that attention is not given to the children, so they end up having some kind of disorders in their development. And I think Dr. Faiza will be taking more in the upcoming sessions about more about behavioral disorder. I'll just give a brief of what is what. So pica, I think we all know. So eating anything that is non-nutritious to the body, non-nutritive, or any inanimate products like plaster, or eating the wall or the charcoal or chalk. So all these things become inappropriate in that particular age group. It can have its own causes and relation, but usually it is some kind of a deficiency, and also it could be that amount of psychological development that is not taken place, or that maternal deprivation, what I was talking about, that also could be one of the reasons. And toilet training difficulties, that becomes important here. Enuresis, by it is bedwetting is okay till the fourth or fifth year of the child life, but if you start having the child bedwet even after 5 years of age, that's when it becomes very important. So until 5 years, bedwetting is still okay. But again, there are more cases of secondary bedwetting which can come in, after the bladder control is taken place. And then that is also very important, because there is some underlying stress or the cause of some kind of fear that is there in the child. So that becomes important. And temper tantrums, like we know, like how there is that anger burst, or that kind of a frustration what the child can go through. So these temper tantrums are usually seen from 18 months to like 3 years. The child is starting to understand itself, and understand who's the mother and who's going to give everything to me, and who's going to be listening to all my tantrums. That's when they start understanding that they can play around what they want by doing this kind of an oppositional thing. So when they're requested to do something, they act totally opposite to it, and they express it in a more frustrated or an angry matter. That is a temper tantrum. So they might kick, they might cry, they might bite, they might throw things, they're hitting things, they are head banging. So all these things again become important for our prescription. But it also is the probably the child is having an abnormal behavioral disorder. So another thing comes is breath holding spells. These are again very it's a outburst of anger and frustration, or even pain, where the child is suddenly crying out loud, and the child is totally loses its breath. So once the child is crying and loudly shouting, the child loses its breath and can also go apneic. So there might be a stoppage in the breathing, and the child can also turn blue. So this is nothing but a breath holding spell. That is again a behavioral disorder from the child. So now the habit disorders are very common, where we see the child having different kinds of habits. Like there are pattern movements, basically like head banging, or rocking the head, or trying to do one particular way of movement, or thumb sucking, or hair pulling, or grinding of teeth. And it's called bruxism. There's too much of grinding of teeth. And also it is thumb sucking becomes also one part of habit disorder, or even lip smacking, where they're always constantly playing with their lips, and that also becomes a thing. And we know attention deficit hyperactivity disorder, ADHD, is one of the most commonest neurobehavioral disorder, if I may call it. And most of the school age children are going through this. And this has a lot, there's no etiology as such, but there is different factors, like even genetic factors can play a big role in this. So that is ADHD. And next things where even we have a lot of scope in ADHD in homeopathy. Other things are all these disorders, we have a lot of scope with homeopathic treatment. And other thing being the learning disability. So dyslexia, or they're not able to the specific neurodevelopment is not happened, and that expected level of learning what that particular child has to go through in that academic year is not achieved by that child, that becomes one of the thing for learning disabilities, probably because of some other deeper thing, like for example like dyslexia. When they're not able to read, it's very difficult for them, and it's the very most commonest thing where they're not able to recognize the word, they're not able to understand the spelling, they're not able to read out, or simple pronunciations are not taking place. So these become like dyslexia, or even dysgraphia, or they're not able to calculate, with difficulty in mathematics, so they're not understanding the whole thing. And then comes the language delay or the disorders in communication. These are nothing but learning late to talk, or learning, the development of the language is taking place much later than the other peers. And things like stuttering speech, like, where there is a lot of hesitation in speaking, or stammering, and, having a big pause when they are talking. These are the other things that can have a disorder, which can have a good impact by homeopathic treatment also. So other major, major psychopathological disorders are, autism and Munchausen by proxy syndrome. And I think autism, I think somebody has already run a session on it. And autism, again, AD, is one of the most commonest, it's actually called as the, pervasive developmental disorder, or it's a spectrum disorder where, autism disorder, or, Asperger's syndrome, childhood disintegrated disorder, all these things come under this pervasive development disorders. So not going too much depth into it. The autistic children are usually, they're not able to, again, the qualitative growth has not happened, and their communication is hampered. Probably their verbal and the non-verbal communication is hampered a lot, and there's a lot of repeated movement, or social interactions are not taking place. There's no eye contact, repeated motions of one thing, lack of social conduct, they're not able to move with anything. So they can, apart from this, they can also have like seizures, or any other kind of genetic predisposition. And this is a very interesting one, that is a Munchausen by proxy syndrome, which you'll see in mostly this is a disorder by the caregiver. So the mother or the caregiver, the primary caregiver, will inflict some kind of illness on the child, so that to create an illness on the child. So that's why it's Munchausen by proxy syndrome. So the somebody else is trying to impart a kind of illness to the child, so that the mother or the caregiver gains some kind of medical attention. This is usually done in substance abuse mothers, where they try to get some kind of medications for the child so that they can utilize it. So they harm the child by doing various things, like you can they usually, infants are victims of these, where the treatment can be like the mother can put the pillow on the child's face, where the child can go apneic or can get seizures, or the suffocation can bring respiratory problem, or there's a fever. These are the things the mother can inflict on the child to gain some medical. This is done by only proper monitoring, and we have to understand by the pattern of how the mother and the child is bringing with the illnesses, and this has to be treated in a more serious manner. So having said that, having a whole overview of different normal developmental milestones and the disorders of development, I've just given an overview. I think there are other speakers who are going to give more in-depth knowledge of each of these disorders, and I think look forward to that. Having said, we can I just highlight a few rubrics so that it's easier for us to look out for when we are advertising, or looking out for remedies. So first thing is the development arrested. So this is when the growth is delayed and it's not moving forward, and you can see there are a lot of minerals that you can see here, like calcareous phos, baryta carb, argentum nitricum, calcarea, and carbon substances. So all these, and even the nosage becomes very important in the practice. And I've seen that intercurrent or like thyroidinum in the delayed development has helped remarkably in delayed development, especially when it is physical delay. And again, if there is a mental developmental delay, so if there's a developmental mental arrested, you can see mostly it's Natromure agaricus. Along with that, we have Baryta carb and Calcarea fos. And next would be things where we are talking delay in speech and delay to walk. So we have it in mind section, talking slow, learning to late. Mainly it is Natromure and Calcarea group, like we saw in the previous case spoken by Dr. Navneet. And again, walking delay, you'll find that in extremities, walk, learning to late, you see all the calcareas and even Natromure with Baryta and some nosodes also. So that is about walking delayed. Also, you can see in the extremities chapter, weakness of lower limbs, that is child learning late to talk. So repertory can show us a lot of hints, but that is not the only way, but we have to individualize the case and see that different things. So we can use it for the general tendency, or you can use it for constitution, like here when the development is not, the growth is not taking place and there's a lot of emaciation. So this is very common, like in lycopodium, emaciation, very thin boys. So what kind of emaciation they are, like more on the neck and less on the abdomen, all those things. And delicate or puny sickly children, that again comes in generalities chapter. This is the constitution or the way the look of the child can give in the repertorial selection. Then again, like I was talking about the learning difficulties. So we can know about Baryta carb, very common, that he learns the same thing over and over again, yet remains untrained. So learning is so difficult for Baryta, and interestingly, even sepia comes there, and it helps when this kind of symptom is there. So even when I was talking to you about dyslexia, they have a confusion in understanding which word to use, or which is B or which is D. That is very prominent in lycopodium. So when dyslexia is there with stammering, stramonium is the main remedy there. And then writing inability to learning to write in children. So that is one of the thing of Baryta and causticum. So there's an inability to write. Then again, like how it's very important to know their vaccination history. So if there is a history of any mental development arrested after vaccination, Thuja comes out to be one of the most important remedy, and that becomes very important in our practice also, Thuja. Again, dentitional problems also, we have medicines mainly being calcarea salts, and even chamomilla works really well here. It's not mentioned, but yeah, it works amazing. And also on the flip side, we have the precocity. So precocity, again, I know Merck comes out far more in the Kent's repertory, but precocity, again, we should not forget the children. I think in homeopathic case taking, we will understand how the child is talking, how well it is. For example, if you see the subrubric of precocity, talking like a big elderly man or a woman, and carcinosum is the only remedy there. So that way we can get a hint towards what remedy to prescribe, so that we can help in the any kind of disorders of development what they are going through. So I think that's the end of it. If you have any questions or queries or anything you want to share, you can always email me or connect me wherever you find me, and we can. I'm happy to help or answer to any of the questions. So shall we end here?
Yes, ma'am. We'll have a question answer session.
Sure.
In another 5 minutes. So I request the audience to please type in your queries in the chat box, so that we can have a question answer session from ma'am. I'll just check if we have any question on YouTube.
Sure. I think there was a lot of theory for them to sink in.
Ma'am, there is a question. What in case the baby doesn't eat but just sticks to one thing like biscuits?
So this again,
From
yeah.
Dr. Deepika.
Okay. So that's one thing that is a condition, what we call it as conditioning by the parents. So if a child is going to stick to biscuits or junk food, only if you introduce it to them, right? So you have to be careful what you introduce to the child. So in the initial periods, what we have to avoid in raising children, and the kind of it again becomes one of the important factors of upbringing also. So if the child is exposed to a lot of these packaged foods and added sugars, or with a lot of preservatives, there is a tendency the child is not going to feel hungry during the actual eating meal timing. So the baby has to first few days, if you remove that particular thing from the diet, the child is going to show a lot of tantrums. The child is going to cry, is going to angry, but you have to be you have to be very strong and not succumb to that cute face, and not give the particular food, I mean biscuit or chocolate. So it's not nutritive, first of all, so it's not needed for you to introduce that in the child's diet. So you have to make sure you deviate it to something more on the healthier option slowly, and then get it out from the diet. So that is what you would have to do for your child. And also in the homeopathic front, if the child is not getting hungry, you can give some other remedies. Like if they have a lot of remedies like alfalfa or gentian and lutea. So if the hunger is not there, and they're not able to eat proper meals, then we can give some medicinal treatment. But giving it as a substitute for food is not a good idea. So I have some questions.
Thank you, ma'am. There is a question. Yeah. There is a question from Dr. Pragya. Can baby walk after 15 months?
Yeah, definitely. So all these things are a range. What I've just told you today is a range. So it is a slight delay, but it's totally okay. It's fine for the child to walk after 15 months also. So it's usually 12 to 15 months is the range what is given for normal time where it's walking. But the child is walking after 15 months also, it's totally okay. If it is walking more later than that, then you can talk about it being slightly delayed. But I don't think 15 months would be, graded as delayed.
Thank you, ma'am. There is a question from Dr. Rajendra. 8 years old boy infected with CMV causes GDD. If since there is no treatment in allopathy, only the management, he's been prescribing homeopathic medicine since last 6 years, but still he cannot walk, speak, eat by himself. Can you please guide in such issue?
It's a great question, actually. So, like I already told, maternal infections are one of the major reasons for growth development delay. And I think here, Dr. Rajendra, if you are already giving him a lot of homeopathic medicines, then think of something as an intercurrent, and preferably a no-sode. So when I was learning under Dr. Sarkar, he had given a child with CMV nosode only. So he has a lot of nosodes. So I don't know if you can procure your CMV nosode, and you can give that child this remedy, and probably it can help out. But any other nosode as an intercurrent will help this child to start developing, and be patient with it. You cannot have the child showing growth milestones very soon, within a month or within 15 days. So be patient with the child. I think you'll be able to help him out.
Thank you so much, ma'am. Okay, so any questions from the audience? What potency do you prescribe in acute skin conditions?
Yes, definitely. Why not?
Okay, I think this was a question for Dr. Navneet.
Okay.
But still, if you want to answer, then it's okay, ma'am. Dr. Navneet is not with us right now.
Why not? Why not? We need to, any acutes we have to prescribe. No?
Yeah. Questions from the audience. There's a question on YouTube, ma'am. What would be the best for time rather
Can you repeat the question? Can you repeat the question? Your voice is breaking. Hello?
He wants to
Yashika, can you repeat the question? Your voice is breaking.
Hello? Am I audible, ma'am?
Hello?
Am I audible now?
Yeah, now you're audible. Tell me.
Yes, am I audible?
Yes, you are audible now.
Okay, so you want to know what would be the best for the best time, I think, for fruit of milky teeth.
I still didn't get. Can you type it in the chat box? Oh, I think she's left it. So here there's nowadays children are very late in talking and any specific reason. It could be many reasons. So delay in talking. It could be one of the things could be that they're not able to they're not stimulated enough. So if that kind of stimulation from the parents or the caregivers is not there, or they're not understanding, or you also have to think that if there are any underlying causes why the child is not talking on time, so you can help with that. Also, it is a learning difficulty for the child. So you can also think, that's the reason why the child is not talking. So it becomes an evaluation how the lifestyle of the child is. Are the parents talking to the child enough? Is the learning has happened from time to time in that particular order? Where the child is at, the level at which. So there's something called as the perceived age and expected age. So is he there in that particular age group? He might be 1 year, but is his milestone saying that he's 1 year or not? So that becomes important. And nowadays I think the late talking is happening because of not enough of the proper probably attention, or the kind of stimulation what it's required for a child. So that becomes very important.
Thank you so much, ma'am. There is one more question on YouTube. How can homeopathy work in oromotor problems in children?
I still didn't answer your previous question. There was some other question that what is the best time, something you were asking?
Yes, ma'am. Yes, ma'am. There was a question. What was the best time? He was asking for timely fall down of milky teeth. What is the time of falling down of milky teeth? Doctor, sir.
Why is your voice breaking?
Right now, ma'am, he wants to know what is the time of falling down of milky tooth.
Okay, like I already showed you that that there are different age groups for each tooth, but around the age of 6 is when they start the teeth start loosening up, and then because there's more, they have to make room for the permanent teeth, right? So around the age of 6, you say the fallout can start happening.
Thank you, ma'am. Any medicine for, I think she has wrongly typed, disarticulation.
Oh yeah, definitely.
Misarticulation. Misarticulation.
Disarticulation, they're not able to talk, or they're not able to make words, they're not understanding. So disarticulation, yes, there are medicines, and I think stramonium comes out to be one of the top remedies for it. But again, totality has to match.
Thank you, ma'am. Misarticulation, it was, she also wants to know about misarticulation.
Can you repeat the question, Yashika? I'm not able to hear you.
Any medicine for misarticulation?
Misarticulation, yeah, there is medicine. Again, you have to understand, like I told you, if there is this misarticulation means that they are not able to pronounce a particular word, they're not able to speak. So we have a rubric in repertory. I'm not able to share the screen now, like lip sync, or even a slurred speech. All these things can be there are many medicines for that. So usually like lycopodium, stramonium, or belladonna. So all these things can help out, and even nosos like medorindum can be a very good remedy.
Thank you so much, ma'am. Oh, Any other question? For oromotor problem in children, how does homeopathy work?
Again, this has to be done with the help of speech and hearing therapy. Only homeopathy will not be of, it won't give you faster results. But once you have taken a constitutional treatment and along with a proper, speech and hearing this therapy, that can be a better mode of treatment than just sticking to only oral medication.
Thank you so much, ma'am. Any other questions from the audience? Ma'am, if the patient is highly irritable, if the child is highly irritable, what can be the best option? Like how to handle the case? Dr. Saurabh only wants to know.
So firstly, when I love it when the child is being himself. So you have in your clinic, if the child is irritable, don't worry, don't react to anything. Let the child do whatever it desires to do. So until and unless the child feels safe in your environment, he's not going to be very easy going with you. So initially, you can start off with a case taking from the mother itself, but your corner of the eye should always be at the child. How that irritation is, like, if in the irritation they are screaming and shouting like the Solanesi family, or are they they are very restless, or they are trying to pull their hair like belladonna. So you have to observe, and observation is the key in the irritable children. And with the observation, you take the case from the parents also.
Thank you, ma'am. Any other queries from the audience? Any other queries from the audience? Dr. Gauri wants to know about congenital diseases. Can homeopathy work in congenital diseases?
Definitely, it can work, but again, depends on the stage of where you are treating at. If the development has happened and there's regression of development, it becomes a bit difficult. But with the gene mutation, there can be a scope only in homeopathy, and I think you should not give up and help the patient as much as you can. So even if the child, for example, I was talking to you about where the child is developed at, which age group, and what kind of skills they are able to do. Now, as a when we are treating such kind of cases in genetic disorders, what happens is we have to make them able to live their life, like how Sir Hahnemann says, the human being has to be healthy in order to perform the higher purposes of life. That has to be maintained. So if with homeopathy you're able to level up at least one step ahead with constant treatment, you're able to at least dress themselves up, at least they're able to walk by themselves, at least they are able to do it with little bit of support. So that is a great booster, and I think that's how we can slowly evolve into giving a long-term benefit in such cases. For example, even if it is DMD case, or let's say cerebral palsy, if it is detected on the earlier stage, you have to start treatment very early so that it doesn't go into the complication. And that is the power of homeopathy, what it can arrest the complications and try to heal the child.
Ma'am, any guidance to treat a cerebral palsy patient?
I saw that thing. That's why I answered both the question together, because cerebral palsy or any genetic disorders, you have to be patient with the child. Along with that, depending on how much of a muscle wasting or nutritional deficiency is there, you have to resort to physiotherapy along with homeopathy for a better treatment option.
Thank you so much, ma'am. I think we have no more queries. I just want to request you, Asha, you have already shared the email on your screen.
Yes.
So, if anybody wants to contact Dr. Sheetal, they can mail at dr.sheetalbidri@gmail.com, or you have any queries for Dr. Navneet Bidani, you can mail at drbidani@gmail.com. So thank you so much, everybody. Ma'am, one last question if you want to answer. Can
Yeah,
you?
thank you.
I think no need to answer. Dr. Shalu, the YouTube video would be available. This recording would be available. You can go for the law of growth and its explanation on YouTube only. You can listen the video again, and you will also receive a replay video of this webinar on your emails. So you can see it as many times through that link also. So if you have any queries, you can mail ma'am at her email ID, and she'll be guiding you whatever the best she can. So I think it's high time that that we should end the session of today. And it was a great session being with you, ma'am, learning about
Thank you
growth and
so much.
development of a child, as well as so beautifully you have explained all the aspects and all the steps, how a child grows and how a child develops. Okay, we have more questions. I request the audience to please mail the questions to ma'am. Whatever queries you have, Dr. Adarshin. I am so sorry. We were running short of time, so you can mail the queries to me at webinar at the rate homeopathy360.com. I'll try to connect you with ma'am, or you can mail directly, ma'am, and ask your queries. So thank you, everybody. Thank you
Thank
so
you,
much, ma'am,
Yashika.
for
Thank you,
sparing.
Yashika and Dr. Homeopathy 360 for this opportunity, and a special thanks to Manish Jain for Mr. Manish Jain for thinking of me for this. Thank you so much, and
Thank
also
you.
Asha Academy and the Homeopathic team.
Thank you so much, ma'am, for your valuable time to our.
My pleasure. My pleasure.
Thank you so much, and thank you, audience, for being such a patient listener for the last 2 hours, 2.5 hours. So thank you, everybody, for being with us. We'll be tomorrow live again at 3 o'clock. YouTube, as well as you'll receive the link for tomorrow's webinar on your emails, whoever have registered. So we'll be joining tomorrow again. We have Dr. Faiza Khan and Dr. Jitesh Sharma's session tomorrow on mother and child, different topics covering mother and child, the behavioral aspect of the child. So I hope we you guys will be there with us tomorrow again. So thank you so much, everybody, for being with us. For any queries, mail me at webinar@homeopathy360.com, or you can WhatsApp me and then at the number I'm providing in the chat box for any queries or any updates. So thank you so much, everybody. Thank you, ma'am. Thank you, Navneet sir. Thank you for being with us.
Thank you.
You have a red sign on your screen, the calling red sign. Can you please click on that? So
Yeah,
that
yeah. Sorry, 1 second. I have exited this one.
yeah.
Yeah.
So we can end.
End the event. Okay, see you.
Thank you.